career as a fireman and emergency medical technician in Washington State. I started out as just a regular fireman and then worked my way up to an ALS provider on the ambulance. During that time I worked, this is before 9/11 obviously, and when people really didn't give a shit about firemen like they do now, so they didn't have the schedules that they have now. So I worked 2 days on, 5 days off. And during that time I was like 21 years old, you know, my first real job, I was making like $35,000 a year, and I was like, man, I have 5 days off a week, and I need a jet ski and a four-wheeler and a Toyota pickup truck and, you know, a bunch of guns and all this kind of stuff. So I was like, oh, I have too much free time, so I need to, you know, do something else so I stay out of trouble. And so I got this job as an armored truck guard. And that's kind of how I got involved with a lot of the people here, you know, in the tactical industry, because I was fortunate enough to have been involved in a couple of interesting armored car robbery incidents that, you know, obviously I walked away from. I also fought in the WTO riots in Seattle in 1999 that you may have heard about. It's, you know, a long time ago, 15 years ago, when we evacuated two of the Federal Reserve banks in downtown Seattle whilst a full-scale riot was going on, and the Seattle police were getting just, you know, plummeted. Just, it was awful. So all this was going on while we were trying to get all of the money that was in the Federal Reserve banks out so that it wouldn't get overrun when the buildings got crashed down and started on fire. So I did that. I went to Skagit Valley College, started out in the community college, then went to a university. I ended up I have a degree in law enforcement. I also have a degree in metaphysics and epistemology, and then I also have another degree in cell biology and toxicology.
So you like school?
Yeah, I do. I do. And you know, this is a picture of me from when I was on the medic unit. At the time, you know, I've grown legs since. At the time, I was just a floating EMS torso. And now, you know, now I have legs and feet, and I'm a real boy. So then I went to the Meharry Medical College in Nashville, Tennessee, where I went to dental school. And then I did my residency training at a couple different hospitals and health centers in Nashville. Currently, I'm the lead dentist in a corporate dental practice in Goodlettsville, Tennessee, which is just north of Nashville, not far from Fort Campbell, Kentucky. My first 3 years in the business was in public health. So I worked primarily at healthcare centers. I worked at jails. Anybody watch that show Justified? When Raylan does interfacility transfers from Harlan, Kentucky to Jacksboro, Tennessee, that was the jail that I worked at, was Jacksboro, Tennessee. Everybody that is an inmate at Jacksboro, Tennessee is there either for the production of methamphetamine, the distribution of methamphetamine, the possession of narcotics, it's usually OxyContin or a Lortab type thing. That's what they're all there for. So there's like 350 people there. As you can imagine, their teeth leave a lot to be desired. So every time I would go there, all I did was pull teeth. Sometimes I would fill up a whole mason jar full of teeth, and then I'd give it to the COs there, and they would put it in the office, and they'd say like, man, you do that, next some bitch, you gonna come in here and pull all your teeth, you know. And so it was kind of
Did they have their teeth?
interesting. A couple of them, yeah. And then I also
Save it up for a full set.
yeah, I also worked for the United States Department of Defense as a dentist for the Dental Corps for the United States Army. I did that. Anybody current past service?
Yep.
So you know, when you get deployed, if you have enough dental problems to make you not deployable, you know, you're category 3, you have to be 3A or 2 to be deployed. So my job was to take out people's wisdom teeth or teeth that they had that were rotten so that they were deployable. And the way that the operation that I worked for did it was that they would fly me out of Nashville on a Friday night in a ridiculously small plane, and then they would give me this big manila envelope with about 80 people's names in it, and then I would go, they'd set me up in some screwy place like the corner of the motor pool or the NVG simulation room with no lighting and a chase lounge and a small autoclave and a couple assistants, and I would just take out teeth all weekend. And the joke was, you know, like if you're a 19-year-old kid and you're getting deployed to Afghanistan and you don't really want to get your teeth taken out, I would say, hey man, listen, I know that you're nervous, I know that you're scared, but if you just keep your mouth wide open, this whole thing will be over in 3 minutes. And that was fairly early on in my career, and I was pretty good at pulling teeth, but you get really good at pulling teeth if you're doing it on a 19-year-old kid who's having an anxiety attack while you yourself are having an anxiety attack. So, you know, I would hold my breath while I did it, and I figured by the time that I needed to breathe, just like I did when I would intubate people, if I could hold my breath and I needed to breathe, then they needed to breathe. If it wasn't over, then I did something wrong. So, you know, you get pretty good at it. I also work on Saturdays, not every Saturday, like obviously I'm here with you. I provide public health oversight at a Hispanic clinic. So all I do is see patients that don't speak English. They're from all over the world, all over Central America, Mexico, and South America. And they come in with all manner of craziness. Anything that you can think of pathology-wise, that's what they show up with. And I've seen the stuff that when I was in school and you learn about in the textbooks, they'll say, you'll never see this in your career, but we're going to show you anyway because it's required. And I would see 5 of them in a week, you know, and people would go like, oh, House is the, you know, most unluckiest guy in the world. And I used to have just a you know, professional Facebook page where all I would do is post pictures of that stuff. And it got to be, you know, something I was doing so regularly that I just kind of stopped doing it because I
enjoyed it.
Good.
It was pretty much always entertaining.
Yeah, well, thank you.
And educational.
I also am a professor at the Meharry Medical College School of Dentistry. I lecture there. I also am an attending for a couple of training programs, residency programs, where we teach new doctors how to do this kind of stuff. I've also been published. I have a few scholarly articles that have been published. And I also have some articles in SWAT magazine and a couple of the other firearms publications that have been.
Do you sleep?
No.
Okay.
And then I'm also a forensic scientist. I do forensic odontology, which is the identification of decomposing human remains based on their dental records. So I also do that. If you ever know anything about the Body Farm in Knoxville, Tennessee, that's where this picture is taken. So that's me. That's me and my boss. Here we go. All right. So every day, I diagnose disease, plan treatment, inject vasoactive chemicals into patients' bodies, perform surgery on their skulls, and I do all of this within 6 inches of their hearts and 3 inches from their brains. I also work upside down, in the dark, and I do all of this in the reflection of a mirror. I tell people this whether I'm teaching lay people or whether I'm teaching people that have been doctors for 25 or 30 years or longer, because I want people to understand that what we do, what I do as a dentist, and what I train other doctors to do is absolutely as serious and as dangerous as any other type of surgery that you may have or require. Invariably. Anything can go wrong when we do any of this stuff, and it can kill you. So if you screw up a wisdom tooth extraction, you'll die. It happens. It happens all of the time. So this is a very important thing. Unfortunately, people have, and this isn't just lay people, this is even physicians. When they look in somebody's mouth and they tell you to say ah, they're looking at your throat. But they're looking past your teeth, past your tongue, past your gums, past all the bone that's in your mouth, and they don't see any of it. And I always kind of joke around because I'll see that these patients, you know, they'll go to their physician and then the physician will say like, yeah, I don't know what's going on with your tooth. Go see, you know, Dr. House across the street and he'll square you away. And then they come back and they see me and I say, hey, what was the deal with all the purpuric lesions on this lady's buccal mucosa? Did you, you know, take a blood count on her and see what her platelet count was? And they go, no. Should I have? And I said, yeah, I'm going to send her back to you because I'm pretty sure she has immune thrombocytic purpura. And then they go, oh. And then they go back and I go, here, look, open your mouth. And then I show them and then they go, oh, shit. He's right. So, you know, our teeth aren't just these magical white rocks that live in our heads. You know, they're living organisms. They are a limb. When we take out a tooth, we are basically performing an amputation. We are removing your functional capacity to perform. You have 32 teeth in your head. You don't really need 4 of them because they're wisdom teeth. But the other 28 are important. If you lose them, you will be sorry. The quality of life that you lose from getting a tooth extracted is not easily replaced, and it's certainly not inexpensively replaced. So, the learning objectives for today. I'm going to explain how dental injury or infection can result in debilitating pain, disability, or even death. I want you to understand preventive measures which can keep dental issues of all kinds at bay. I'll help you assemble and use an intuitive dental emergency kit. And I want you to understand which over-the-counter prescription medications are useful for the management of dental emergencies. Dental anatomy. This is just a graphical representation of what happens in nature. What happens in nature is never as pretty or distinct as what happens on these slides, that we use for educational purposes. If it did, life would be so much easier. It'd be like fixing a person made out of Legos, But it's never like that. It's never that easy. So the part that we see when we look in our mouths is we see the crown of our tooth, and the crown of our tooth is made of enamel. Enamel is the hardest, densest tissue we have in our bodies. It's harder than bone. It's obviously harder than your fingernails, everything else. The next most dense tissue is the dentin. In the UK, they call this dentine. So sometimes if you look this stuff up on the internet, it'll say dentine instead of dentin. Same thing. And dentin is a little more yellow. Enamel, if you actually took a piece of enamel and cut it off the tooth, like if you took a saw and you went like that and you held it up to the light would go through it. If you took a piece of dentin and you cut it off right here, held it up to the light does not go through it. The reason that our teeth and some people's teeth appear more yellow than other people's teeth is because our teeth are actually yellow. They're not white. When you say, I like to whiten my teeth with Crest white strips, they should call them Crest less than yellow strips, because that's really what they are. They don't actually make your teeth whiter, they make your teeth less yellow. So dentin is yellow, enamel is kind of transparent, so you get sort of a prism effect of it showing through. Now, inside this tooth, the rest of the tooth is made out of dentin. And inside, there's this little chamber, this hollow space, that's called the pulp chamber. And descending from the pulp chamber down into the bone that surrounds the tooth are the canals, the root canals. Now, when someone says, I've had to have a root canal before, I tell them, that's not true. You actually have about 56 of them, maybe more. So a root canal is a location. It's real estate. It's not the name of something. Everybody has a root canal. If you've had root canal therapy, that's a whole different situation. So inside this pulp chamber and extending down into the bone, there are arteries, veins, lymphatic channels, and nerves. This is very, very fragile, friable tissue, meaning that it doesn't have, adult teeth have almost no regenerative capacity at all. So it's not like, if you get socked solid in the tooth, your tooth might hurt for a few days, and then it'll stop hurting. And then maybe a few days later, or a few weeks later, it'll turn brown. We all know the brown tooth person, When it's somebody that you go like, oh, they're awesome, but they got this brown tooth, which they really should fix that because it's semi-sociopathic. The reason that they have the brown tooth is because the tooth got hit, it killed the nerve tissue in here, and the vascular tissue. It all basically turned to pus and fell out the bottom of the tooth. And then because this tooth was injured and bruised, the tooth started to take up the products of decomposition from the blood, just like you get in a bruise, and it turns the tooth dark because the tooth holds basically the decomposing blood. If you get hit in the arm, you get a purple bruise that turns green, and then it turns yellow, and then it goes away. And that's because through a degradation of the blood products that are in there, it goes from, being in a state of inflammation and injury to back to a healthy state. Same thing with the tooth. This is an actual cutaway of a tooth. So this would be the front. If you imagine if we took a saw and cut right down the middle, right down here. This is the front of the patient's mouth. This is the back of the patient's mouth. So we're looking at the side of the tooth as if we cut their cheek off and we're looking into the side of their head. So what we see here is this is actual life. So you can see here, this is the enamel, that I was telling you is semi-transparent, the densest material in our bodies. This is the dentin that's below it. The dentin you can see is much more dense and is a darker color. The problem, and then of course here's the pulp chamber and the root canals. Now the problem with this picture here is this. This is a cavity. Now if you imagine, if you will, that there is another tooth right here next to it that would follow the same contour that this tooth has. The area where this decay, where this cavity has formed, is where those two teeth touch. Now, everybody in here has flossed their teeth at least once in their life, I hope. When you take that piece of floss and you pass it in between your teeth, and it passes and it kind of makes a little snap through, and it snaps coming out. The reason it's snapping is because it's coming through this contact area between your two teeth. If you do not floss your teeth, decomposing food and bacteria aggregate in that space between your teeth, and it results in a cavity because those bacteria love to eat. And when they eat, they produce a byproduct of their metabolism, just like humans do. We produce carbon dioxide as a byproduct of our metabolism. We breathe it out when we breathe. These bacteria, they don't have lungs. They don't breathe out the same way that we do, literally. They release lactic acid as a byproduct of their metabolism. And the acid eats a hole in the tooth. So if you don't remove that food particles, you're basically just giving the bacteria that live there lunch, dinner, breakfast, for however long you don't floss your teeth. And they just continue to produce acid, and the acid continues to eat a hole in the side of your tooth until it gets in here. Now bacteria move into the spot, that they eat a hole in, and they get into the softer part of the tooth, the dentin. Now it's a dense tissue. It's not as dense as enamel, like we said, but it's much more nutrient rich. It has much more organic substance to it than enamel does. Enamel is mostly inorganic compounds. Dentin is not. Dentin is more tissue, and bacteria love to eat tissue. So once they get into the dentin, they go absolutely chainsaw ape shit, and they eat their way into the tooth. And what will happen is before long, if you just have this cavity here, you're not going to feel it. You're not going to notice it. You're not going to feel it when you floss your teeth, but you will feel it once it works its way down here into the nerve of the tooth. The only way that you can detect these kinds of cavities is by going to your dentist and having x-rays performed. I can't see these when I look in your mouth. They are not accessible to my eye, but I can see them on x-ray. So if you have one, we fix it. This doesn't happen. If this works its way, the decay works its way down here into this tooth, that's going to cause you a toothache. Now, your tooth, like I said before, the tissue inside the tooth is friable. It's delicate. It damages easily. Once it swells up there's not enough. This is an incompressible space. This is like a cave in here. You're not going to get any more space. This tissue around it is not soft enough to create space to accommodate swelling. So when the tissue in here swells up, when it gets insulted once, it dies because there's no more space for it to expand to. And it crushes those blood vessels. It doesn't allow blood to go in there. If you cut off the blood supply to something, what happens?
Dies.
It dies. And it dies, and now the tooth is dead. So you get a toothache once. After that, the tooth is dead. And the next thing that's going to happen is the tooth is going to abscess. So people will say to me all the time, Dr. House, I have 4 children. I delivered each one of them naturally, and it hurts nowhere near as bad as this toothache does. How is that possible? Or I have guys that come to me that are, especially in the Army. Like some of these dudes that were SF cats that were, ate bowls of broken glass for breakfast and had tattoos from their ass to their elbows and had been blown up multiple times. And they'd say, dude, this tooth is fucking killing me. Why does it hurt so bad? Well, here's why. All of your teeth in your upper jaw and in your lower jaw are innervated by the same nerve complex. Now, I'm not going to hit you with all of the names of the nerve complex. If you want to know it, I'll be glad to tell you, but I'm not going to over-encumber you with it. But think of this. There is an area here that all of the signals of the nerves come to. It's almost like a substation. And then there's wires, if you think of the nerves as wires, that come out of that substation and innervate, they return messages from the parts of the body. That substation lies up here in your head. This kind of shows you a side view, but if you look at this picture, this is if I took a saw and right about above your eyebrows ran that saw all the way to the back of your head. Took the top of your head off, lifted your brain out, and took out a little bit of your spinal cord and your brain stem so that you could see behind your eyes and right underneath your brain is where this substation is. So if you can imagine, the worst place to get a headache is behind your eyes and underneath your brain, because you can't touch that. You can't rub your temples and feel this. This is inside the middle of your head. This is the midline of your head right here. And this is where that is. And you have one on either side. Trigeminal ganglion is what this is called. This is also called the trigeminal nerve. It has 3 branches. Tri means 3. Gemini in Latin means the twins. Okay, so we have one on either side. That's why dental pain is as acute as it is. It's not like when you stub your toe and you go, ow, I stubbed my toe. That really hurts. This is a whole different kind of pain. It's actually in your head. This is a panoramic x-ray. This is the type of x-ray that I would take to take out your wisdom teeth if you were doing your pre-appointment exam. This young lady here, she's 23 years old, still has her wisdom teeth, is going away to college, wants to get her wisdom teeth taken out. So we took out her wisdom teeth. I'm showing you this because I want you to see what I see when I look at an x-ray. A lot of people are under the impression, and what they kind of get in their head, is that an x-ray is what you look like when we skin your head. If I peel all the skin off of your head and I look at this, this is what I see. Which is sort of true, but not really true. When I look at an x-ray, I'm not thinking of how do you look with your skin off. I'm thinking of what's going on in the densities and all this here. So when I look at an x-ray, I'm looking for changes in density. Now, as we talked about before, the hardest tissue in the tooth is enamel. It's the densest tissue in our whole body. And if we look, like on this tooth here, this wisdom tooth, you can see there's this kind of lighter gray colored spot. That's because that's the densest part of the tooth. That's the enamel. Over here, this is metal. She has metal fillings all throughout her mouth. She has a metal crown here, porcelain fused a metal crown here and here on tooth number 2 and tooth number 3. You see how the crowns show through white? That's because x-rays do not penetrate metal. It hits metal and it bounces right back off. So it leaves a void of color on the x-ray. So this metal is far more dense than the enamel. We can tell that by the x-ray. Now, looking at the bone that surrounds all these teeth, we can see that the bone is considerably less dense than any part of the tooth. Yes? Okay. Now, if we look up here in the midface, where this is where your maxillary sinuses are, and where your nose is, this is your nasopharynx and your sinuses, it's very thin. In fact, it's so thin that, you can put a bright light, like a surefire light, up underneath your lip and transilluminate your sinuses. It's something that you can do. It's very thin. So, and that'll come into play here a little bit later in the presentation with a special treat. But I wanted you to see this because I want you to see what I see when I look at an x-ray, which is I'm looking for changes in density. When I find tumors in people's jaws, I'm looking for changes in density. I'll see them here, or I see them here, or sometimes I see them here. And when I see that, then I go, well, that doesn't look right. And there's only a few things, that it narrows my area of suspicion down to about 3 different things that it could be. And to date, I found 7 cases of cancer this way, and probably about 150 different kinds of benign tumors of various sorts. And then occasionally, like, somebody will come in and they're like, my face hurts really bad and my gums are bleeding. I take an x-ray like this and I say, what did you do last night? And they say, I went to the tavern. And I say, did you get in a fight? And they said, well, kind of. A guy punched me in the face. And I said, well, your gums are bleeding and your face hurts because your jaw is broken on both sides. And I see that because I look here at the condyle and I can see that it's fractured. So that's what I look for when I look at an x-ray. I look for density. So, you say death. You can die of a toothache. How can you die of a toothache?
Let me count the ways.
A number of ways. The first way is septicemia. Now, like the first slide that I showed you of that tooth on the 15-year-old child, he, you know, is there any medics or EMTs or first responders in here? Okay. So, years ago they used to do this assessment technique, and I don't know if they do it anymore, but I really like it. I still use it to this day, of the sick, not sick patient, you know? So like you'd walk into a room and I go, hey, how you doing? I'm, you know, Sherman House, da, 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 da. And then I go, you know, this person's sick, or this person's not sick, you know, and you're like, well, I fell off the toilet, and then I thought I'd call you guys because I need to take my water pill, you know, not sick! But, you know, if you walk in there and you're like, hey, 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 you know, and they're like, oh, and they're, you know, kind of half asleep, and they're sweaty, and they're tachycardic, you know, their heart's racing, their blood pressure is low, you know, they've got something else going on, and if it's a tooth, they're already on the downward slope, so it's time to move. So septicemia. And septicemia, if you want to think of it in functional terms, what's going on is you now have an infection in your head that has outstripped the performance capabilities of your immune system. Your immune system can't race up fast enough to catch this size of this infection that you have acquired. So, that's septicemia. An airway obstruction, like people go, you can get an airway obstruction from an abscessed tooth? Absolutely. I've seen ones that are lower teeth, you know, jaw teeth, mandibular teeth, that swell up to the point where the person will actually have tracheal deviation just the same that they would as if they had a tension pneumothorax. The difference is, you can decompress them all you want, and it's not going to do a damn thing, because what's causing them to have tracheal deviation is the fact that they're filled with pus. Their neck is filled with pus. Now, there's 2 kinds of fascial space infections that I'll talk about. A fascial space infection is this. Everybody in here eat meat? Yeah. Mm-hmm. Everybody's eaten chicken before? Mm-hmm. So you know when you kind of are tearing through a good piece of fried chicken, there's little pieces of semi-transparent tissue that separate the muscles in the chicken. That's fascia. So what happens is, in your neck, and your head and your neck, everything is so closely related. There's no free space in your head, you know. It's filled with tissue, it's filled with blood vessels, it's filled with nerves, it's filled with lymphatics. There's just no space for anything. So there's all of these little fascial walls that separate and keep everything segregated and unified in our heads. The problem is they do such a fine job that when you get an infection, there's no place for the infection to go. So what it does is it kind of wiggles its way in between these walls, and it starts to work its way out, and work its way out, and work its way out, until it starts to actually dissolve that tissue. Now it's creating new spaces. So it will move from one space to the next, to the next. And one of those things that can happen is you actually end up getting a fascial space infection leading to mediastinitis. So your mediastinum, that's the compartment that your heart and the great vessels of your heart lives in. That's a bad thing. Anytime you have pus or infection around your heart, it puts mechanical pressure on your heart. You know, you can get like a pericarditis, pericardial tamponade type thing. But you can also get just a straight up bacterial infection in your heart, which is also going to give you septicemia along the way. So these people don't do well. They usually have some other kind of comorbidity, and they end up, you know, dying in the ICU, if they are in the ICU. If you're in a third world country, they're probably dying in a tent somewhere. A fascial space infection leading to cavernous sinus thrombosis. That sounds like a big thing, and basically what that is it's an infection that ends up getting into your brain. There was recently a case that made national news that was a 10-year-old child in Washington, D.C. Again, mother on Medicaid. And the child had a baby tooth that became infected. The mother did not treat him appropriately, didn't take him to the hospital, apparently didn't need any Lortab, and the kid ended up getting an infection in his brain that killed him. This is in Washington, D.C., you know, the home of the leader of the free world, and we have kids dying of infections that normally only happen in third world countries. So, that's a 10-year-old kid. The last thing is it can be a nidus of infection for infective endocarditis or peritonitis. So, your heart or the compartment that surrounds your guts can also end up getting infected because of it. The two main groups of people that we look for that this happens to with infective endocarditis are people that have valve problems, people that have had scarlet fever as a child and had a valve issue, people that have had some kind of calcification on their valve or damage to their valve and they have to get a porcine or a mechanical heart valve put into place. Those people are the most common groups that get infective endocarditis. Peritonitis, most commonly we see secondarily as an infection in people that have joint issues. So, you know, they've had a hip replacement or a shoulder replacement. And they'll end up seeding infection from their teeth into their joints. And that always ends up bad too, and the orthopedists don't like it because then they end up having to redo the surgery and it screws up their numbers.
So is that also an issue for MVP?
Sort of. Mitral valve prolapse, MVP, used to be something that we always routinely pre-medicated patients for if you had it. Now, in 2007, the American Heart Association changed the guidelines and said that the only people that we pre-medicate now for infective endocarditis are people that have a demonstrated valvulopathy, meaning that the valve is damaged, or if they've had a replacement. So if you have MVP and you've had valvular damage, then yes. But MVP by itself is no longer something that we pre-medicate for. Good question. Prevention. This picture here, what do you think of that? Pretty horrible, I think. This is the result of, what do you think this is the result of? What is it? Meth? Okay. What did you think it is?
Crack.
What is it? Not flossing. Yeah, this guy's never flossed for sure. He uses dental floss to put up Christmas ornaments. That's about it. Anybody else? What do you think? This is Mountain Dew. This is Mountain Dew and never brushing his teeth. This guy, his name was Steve. Oddly enough, he looked like Steve Buscemi. And he was the custodian at Northcrest Medical Center where I had an office. And he used to come into my office every day, and he would be cleaning the office shortly. He cleaned the office, and then I got there, and then he would leave. The problem is that I could smell him for about an hour and a half for 2 hours after he left every day because of this smell that came out of all of this. So one day I told him, Steve, please come see me, and I will gladly fix your teeth. And he said, oh, I can't afford to have them all taken out. And I said, just come see me, and I'll take out your teeth. And so he came to see me, and I just took out his teeth, and I just kind of thought of it as a way of doing public service because I didn't want to smell him anymore. And nobody certainly wants to look at this. It'd be much better to look at him if he had dentures, you know? So we took out all his teeth. He's 26 years old, took out every tooth in his head, and made him a set of dentures. So, prevention. What does this picture have to do with prevention? Well, the reason that Steve's teeth got into this condition was twofold. Number one, his oral hygiene was absolutely lacking. And by lacking, I mean never. Never brushed his teeth. Not once. And I said, Steve, didn't your parents ever say to you, like, hey, Steve, it's almost time to go to bed. You should go upstairs and brush your teeth and get your pajamas on. He said, no, they never said that. I said, did they just say, like,
Don't brush your teeth.
you know, get ready for bed. Here's a handful of gummy bears and some Mountain Dew. And he'd say, yeah, pretty much. And he said, my parents wear dentures, my grandparents wear dentures. Everybody has false teeth. And I thought,
Aspirations.
okay. So this is what an absolute lack of prevention will do for you. Now, if I showed you this x-ray, remember what the panoramic x-ray looked like from a couple slides ago? If I showed you his x-ray, you would see that Steve has 32 teeth, never had a tooth extracted. He lives out in rural Tennessee, Springfield, Tennessee, about 20 miles off coast. And, you know, they don't have fluoridated water out there. So that's maybe a contributing factor, slightly. But I don't think he drinks a lot of water. And he certainly doesn't put water in his teeth when he brushes his teeth because he doesn't brush his teeth. So he's in a semi-rural environment. However, I wouldn't say he's in the third world, but he has a third world health condition because of the situation that he's put himself into. Now, the third world is a dangerous place, and dental infections kill people in the third world environment. I hope by this point in the presentation I've demonstrated to you that the third world is not necessarily anywhere that is outside of the United States boundaries. It is well within our boundaries. And it is also situation dependent. Take New Orleans, for example. You know, first world, Katrina happens. Now it's become a third world country. We have running gunfights in the street. We have no clean drinking water. We have an absolute dearth of medical supplies and providers. And something like this, that in a normal environment, wouldn't, you know, it's not going to hurt him until it hurts him. Something like that, what's it going to do then? You think there's a lot of dentists running around with waders on, you know, saying like, hey bro, I can help you with your tooth. Just come sit over here in my submerged lawn chair and we'll pull your teeth. You know, I don't have any supplies to be able to do that. So unless you really want to, you know, gut through this thing, we're kind of screwed. If I showed you this guy's x-ray, if I showed you Steve's x-ray, you'd see that he has 32 teeth. Of those 32 teeth, 25 of them have abscesses that are the volume of a sugar cube. Jesus. So if we took, everybody knows how big a sugar cube is, right? If I took 25 sugar cubes and stacked them up on this table, and we replaced that with cubes full of pus, imagine, can you imagine walking around with that much pus in your head every day and trying to live and do your job and be a father and drive a car and do all this other kinds of stuff when you have all this going on? It's insane, and it's dangerous, and that's what kills people. How this guy pulled this off for as long as he did and made it to the ripe old age of 26 is beyond me, because I know that this had to hurt. You know, he had episodic tooth pain after tooth after tooth after tooth after tooth, and he ignored it and ignored it and ignored it. So, you know, not everybody has money to get their teeth pulled, but I can tell you with absolute certainty that within 100 miles of wherever you are, if you are within the United States, there is a federally funded health center that you can go to and get your teeth pulled for free. You might have to wait in line for a day, but it'll get done. It'll get done. So, how do you keep out of my chair? Well, you shouldn't keep out of my chair. I should see you every 6 months, whether you think you need to or not. Because I can't see that decay, and you can't see that decay that grows in between your teeth without the help of x-rays. It can't be done. I would like to see people, like I said, every 6 months, so twice a year. And if you see me twice a year, generally you don't ever have to see me with a drill in my hand. Because anything that you have, we can catch early enough that we can sometimes treat it non-surgically. I mean, we don't have to cut a hole in your tooth and put a filling in there. We don't have to do a crown. We don't have to do root canal therapy. We don't have to extract teeth. There's a lot of stuff that we can do. If we catch it early, it's a lot less invasive. And I'm a very, you look at me and you probably think, good God, this man is a butcher. You know, like he just is he pulls all this horrible stuff out of people's heads. But I'll tell you, and all of my colleagues will tell you, that I'm a very conservative doctor. I do exactly the least amount of invasive treatment that I have to. But in this guy's case, there's nothing that's going to fix this other than removing these teeth, mowing the bone down, and then making it comfortable for him to be able to wear a denture. That was the least conservative treatment option for his condition.
Did you do anything to help his gums? The receding gum line?
Well, after you take out his teeth, it's a moot point. Yeah, I sew it all up. Yeah. So, the last thing about here is daily brushing and flossing. And I always tell kids this, you know, because kids, I recommend that people start taking their kids to the dentist as soon as the child has teeth. Yes, I realize that a 6-month-old is not going to sit still in the dental chair. But if I can have them sit on the parent's lap, and I can walk in there with my mask and my glasses on, and scare that child and get them to start crying, I can look in their mouth and see what's going on with their teeth. And yes, they cry, and it takes about 10 seconds for me to do, and then they go on their way. If I see something that's alarming, we act and we do something else, which involves sedating the kid, and it's a long, convoluted story. But, you know, about the time the kids are 6 to 8 years old, depending on how their dexterity is, that's when they're able to start taking care of their own teeth. And I tell these kids when they come to my office, hey buddy, you don't have to floss all your teeth, you just have to floss the ones you want to keep. And I used to tell kids this all the time. And you know, kids kind of would like listen to me and go like, you know, like they don't get it. And I used to kind of get bummed about it because, you know, I have a kid that's 8 years old and I tell him this kind of stuff and he gets it, and I want these kids to be able to get it. And they don't get it, you know, for a variety of reasons. So I changed the way that I do it. Now I tell these parents, instead of me even talking to the kid and telling them, you know, like, you really need to brush your teeth, little man, you know, I say, this is what you need to do. Like, I tell the mom, I'd say, listen, it's going to cost several $1,000s for you to fix your kid's teeth. So it would be a really good thing for you to follow them into the bathroom at night and make sure that they're brushing the hell out of their teeth. And even floss them once in a while, why don't you? Okay? And then the mom says, you little mister, you get your butt out to the car. You know, and after that, they come back and the flossing and the brushing is getting done. So I have to put a financial reward penalty on it for the parents to be able to enforce dental hygiene. It's sad.
How do you feel about water picks?
Water picks, air flossers, mouthwash are all useful adjuncts, but only if you are brushing and flossing. They don't do anything that a brush or a floss will do. They only do other things that you don't necessarily need, that your saliva and your tongue will also do independently. Yeah. Unless you have periodontal disease, you know, and you have some gum recession, they are a little more useful to kind of like get in the nooks and crannies, but again, you can still just use a floss or a pick for that. So, daily brushing and flossing. I say daily brushing and flossing. There's no frequency that I've written up there as far as like how many times a day should you brush or floss your teeth. The reason I put that is this. I brush and floss my teeth more than I should probably. I brush them and floss them after every time I eat. Sometimes I floss my teeth 5 or 6 times a day. If I'm eating something that's like really granular, you know, like if I eat peanuts or if I eat almonds or things like this. I would like to see people brush and floss their teeth at least in the morning and at night before they go to bed. If they can pull off 3 times a day, if they have the kind of career that supports that, you know, or the schedule that supports that, I'm very happy about that. At the absolute bare minimum, though, you got to brush your teeth when you get up in the morning.
Yes.
And, you know, like, when you get up in the morning or when you go to bed at night, well, here's the thing. This is the way I look at it. Overnight, the stuff is all grown in your mouth, so you're getting it off in the morning. If you don't get it off at night, it grows there all night. So it's kind of like 6 of one, half a dozen of the other. It's either going to sit on your teeth all day or it's going to sit on your teeth all night. If you're a mouth breather, that's probably a better thing because the bacteria, grows better. Certain bacteria grows better in the absence of oxygen. So, you know, it's kind of a screwy thing. But the literature shows us that if you do have adequate oral hygiene, you can get away with once a day brushing and flossing. But like I said, I prefer to see 2, because that's only if you do it perfectly. And we're humans. We don't really do anything perfectly every single time, every day. So if we're brushing our teeth 365 times a year, I would hope that maybe 320 times out of that year, it's going to be brushed well. So, now, pathogenesis of an abscess, or the foreign body reaction. Patho means disease. Genesis means beginning. So how do we begin this disease process of an abscess? I like to think of an abscess as a foreign body reaction. Like I told you guys early in the presentation, these are not magical white rocks that live in our mouths. They are living organisms. They are limbs. They react no differently than any other limb that we have. Science doesn't change. It operates the exact same in our mouth that it does everywhere else in our body. So these teeth, like we've talked about, have no regenerative capability, or very little regenerative capability at all. So we saw the picture earlier about a cavity. Here's another cavity that's progressed. It progresses to the nerve. It kills the nerve. The tooth becomes insulted. It dies. Then it undergoes pulpal necrosis, which just means that the pulp has died. Necrosis, necro means dead. The pulp dies, and then it begins to decompose. Now, just as every one of us in this room, at some point in the future, is going to die, we will decompose. And, decomposition, if we say that, because of all the forensic stuff that we've been continually programmed with, everybody thinks of it as like a really gross process. But when you think about it in terms of science, it's actually pretty cool, because you're kind of turning yourself into a compost pile. You're going from being a living organism, now you're dead, now you're going to return to the earth. And it sounds like hippy-dippy bullshitty, and you're probably like, man, this guy's from Washington State and probably has a whole collection of North Face jackets. I don't. But I have a Carhartt. But worms eat you, you become food. All the bacteria that's in you cracks its way out of you and continues to eat you. It's kind of a fascinating process. And I could talk about that, for another 2 hours. But in a tooth, what happens is the same kind of thing. Those blood vessels, they fall apart. The lymphatic channels, they fall apart. The nerve, it falls apart. And it all turns to pus and leaks out the bottom of the tooth. So you might say, like, I've seen pus before because sometimes I get big zits on my forehead, and when I pop them, they hit the mirror. True. In a tooth, it's a little bit different, though, because our body realizes, hey, something's going on with the tooth there, and there's pus leaking out of the bottom of it. Let's send a bunch of immune cells there. So immune cells show up, and they say, hey, we don't want this pus to go anywhere other than right here. So we're going to try and limit its exposure, and we're going to build a little wall of skin around it. And that's what, like when I pull this out, I call this a cystic sac. Sometimes I'll call it granulation tissue, depending on what it is, but it's all the same thing. It's basically a fluid-filled sac. It's a piece of skin filled with pus and a bunch of dead immune cells and some live immune cells. There's a little cocktail of interesting science and microbiology going on in there. So, if I take your hand, Ian, and I take a piece of cedar and I jam it into your finger and then I spit on your hand and rub it in there, how long do you think it's going to take before that starts to become irritated?
Almost immediately.
Yeah, not too long. It's going to start hurting, and then probably over a period of 24 to 36 hours, it's going to be red, and it's going to be hot, and it's going to look angry, and there might even be some pus leaking out of it. Just as that sliver sits in your hand and begins to pustulate and fester and hurt, the only thing that's going to fix it is to take it out. If you have this sliver in your hand. It makes sense, right? Doesn't it?
Yeah.
Okay, so every day I do this stuff. Every day. I pull anywhere between 30 and 200 teeth per day. And I have patients that walk in, as an emergency, and they'll tell me, I have an abscess and I need to get this tooth taken out. And I say, yeah, I agree. And they go, but I need to have antibiotics first. I went to this other dentist and he said I need to have antibiotics first. I called my mom, and she used to clean at the emergency room, and she says that I need to have antibiotics first before I have this tooth taken out. And I say, no, you don't. Now imagine this. Okay, let's say that's established logic. Let's say that is the SOP, right? You come to me with a sliver in your hand. and I say, you know, well, how about this? I'm going to give you some Keflex. I want you to take this 4 times a day for 5 days, and then you come back, and I'm going to take that sliver out of your hand to restore your functionality so that we can get you back to whatever you were doing before. Wouldn't you think, would you want to slap me in the face and ask for your money back?
Yes.
So, it's no different in dentistry. The argument that these people will make, and some of these dentists that don't understand science, is that they'll say, well, the tissue is acidotic because it's hyperalgesic, and you have all of these, you know, the pH has lowered in that level, and the anesthetic is ineffective. True. However, there's nothing that says that we have to put the anesthetic in the area that's inflamed. I can put it far above it, and I can take out the sensory issues to that area way up here in your face. I can take them out below your eye if I have to. I can put a needle through your greater palatine foramen into your maxillary nerve and put the whole base of your skull asleep, and you won't feel a thing. The difference is that it takes technical precision and accuracy to be able to do something like that. And the only people that have that are people that are good surgeons. If you are not a good surgeon, you are better off to take this person that comes to your office that has this tooth and send him to me. Or send him to an oral surgeon
And you're in Tennessee,
that will
right?
do this kind of stuff. Yeah, I mean,
Okay.
you know, if you're, I'm not going to say, like, send me somebody from Fort Worth, you know, like, flying, although that does happen. The furthest I've ever had a patient travel to see me was 4,100 miles. Wow. There was a guy that is a friend of mine through the tactical industry that was going through the selection process to become a Royal Canadian Mounted Police, a Mountie, and needed to have his wisdom teeth taken out. He was 32 years old. Every surgeon that he went to in Canada said, I'm not taking those out. And he sent me the x-ray and he said, will you take these out? And I said, sure. He was down in our area to do some type of firearms training, and he came to see me at the end of his training evolution. I took his teeth out. He stayed at a hotel near the airport for 2 days until he was recovered, flew back 4,100 miles to the Great White North. So, just as this sliver festers and becomes further infected and inflamed, so does an abscess too. The only thing that's going to fix this is to take it out of your head. It needs to go. There comes a time when the sentimentality needs to leave the equation and realize that the only thing that's going to fix your problem is cold steel and sunshine. And what I mean by that is I'm going to use a metallic instrument to remove this from your head and put it onto my tray where it's going to get hit by the sun. Because that's the only thing that's going to fix this. So, as whether you're a healthcare provider, whether you're a lay person, the rules of science don't change. They're the same everywhere, through every person, through everybody in this room. None of us are Dr. Manhattan, and I really wish that I was sometimes, but we're not. We all operate the same, regardless of our ethnic background or whatever. We all bleed the same kind of blood. So if you hear these outrageous claims that seem counterintuitive, the chances are they probably are. Not factual and not congruent with current scientific belief. So I tell you, if someone tells you something crazy, go to a different doctor and get a second opinion. Because you never know. Now, what are the signs and symptoms you will encounter in a patient with a dental infection? You know, you guys notice a recurring theme here. Each one of these pictures that I show is relevant either directly or tangentially to what we're talking about as far as the content of the slide. This patient, this is a woman that came to me because she needed a filling in her front tooth. That was what she said. That's what she told the front desk. I need a filling in my front tooth.
What
Now,
is it she's gonna fill?
right. If you look at this tooth here, this tooth is what she was complaining about. It had broken off. If you imagine, you know what an apple core looks like? There's a decay pattern that occurs that you can see starting here and starting here. If you imagine if this continues, it continues to erode into here, the tooth ends up looking like an apple core. Well, the bottom part of the apple core snapped off. That's why she thought she needed a filling, that I could just graft some plastic on there and have this tooth look like this tooth again. Not paying attention to the fact that, oh, well, this is coffee stain, is what she told me. This is because I smoke, and this one over here is because sometimes I drink Coca-Cola at lunch. As if each one of these teeth only comes in contact with each one of those unique fluids that she puts into her mouth.
And this one is Fred.
Yeah, right, exactly. So this, she has a mouthful of problems, but this is her current problem. Now, no filling is going to fix this. If you see something like this in the field, or if you have someone in your family or your group that has something like this, you know, somebody's been asleep at the wheel. No amount of anything other than surgical intervention is going to fix this. So, what kind of signs and symptoms are we looking for? We're going to see redness. See this? This is angry tissue. This is what angry tissue looks like. Normal tissue doesn't look like this. If you've ever looked in your mouth and you've seen this, then you know that you've got something going on that is not congruent with a state of health, okay? Swelling. This is swollen. You see how it looks ugly? It looks puffy. It looks not normal. It doesn't look smooth and graceful. You can't see the bone underneath the gums, which is also a bad thing. And it just looks ill. This patient, obviously, they might have pain. This lady didn't have pain. She just wanted a filling. That's all. That was her motivation coming to see me. She had no pain at all. At that moment, she denied having any pain with that tooth in the past. However, I don't believe her. Maybe she forgot about it. Judging from her overall health, she probably has pain so frequently that it's a routine part of her life. Pus. A pus is a big giveaway. This tooth here in particular, you can't really quite see. It's hard to get these things to focus sometimes. But if I took an instrument or my finger even and just push on this tooth, it's compressible. It moves. It shouldn't move. And when I push on it and it compresses from the sulcus, which is the space that's around the gums here, pus just oozes up like that and comes creaking out of there, and it makes you go like, okay, well, we're a little, I know exactly where we are, and the only thing that's going to fix this is what? Cold steel and sunshine, right? Okay, so pus smells. Pus smells like a combination of rotten tube socks or a Spanish whorehouse at low tide, depending on where you traveled before the war. So it's not a pretty thing, and once you smell it, you'll never forget how it smells. And if you are talking to somebody that has this in their mouth, you'll know it. And it's not pleasant to talk to somebody that has periodontal disease that has pus in their mouth. Like, when you talk to them, you will go like, hey, Jim was a really nice guy, but holy smoke, like his breath could kill a pony. Like it's just bad. So the pus and the bad breath, that halitosis, that's what that is. Malodor is just a bad smell. Fever. These people, if they're constitutionally ill, if their infection has outstripped the capabilities of their immune system or is attempting to, they will develop a fever. The reason that our bodies develop fevers is because our body is attempting to do a couple things. If it changes the operating temperature of our body, it affects bacteria's ability to work, because bacteria work in a very specific range of circumstances. The other thing is that people actually work better when our temperature is slightly elevated. All of our metabolic functions can work faster. Think about it. Like if we take something that can move along at a certain speed at a certain temperature and we make it hotter, it can move faster because now it's metabolizing faster, I guess is the best way to say it. You go out in the cold, your bones get creaky, everything kind of slows down, all your blood sucks in, and it makes things a lot harder to work. You get your muscles warmed up, like before you do a workout, you do that same kind of thing. So basically, our body adjusts its thermostat to attempt to combat this kind of stuff. And if it's adjusted, and it's adjusted up, then that person will display a fever. And it might just be a low-grade fever, 100, 100.3. If it's higher than that, they're probably already at the point where they're septic. So, the ice skate versus Tom Hanks. I'm talking here about that movie, Castaway. And I don't know how he did that. And I've spent hours thinking about it, how he did it. And I've even thought about like contacting the Mythbusters and saying like, hey, I'm a dentist, this is what I do all day. Why don't you guys come out here and let's figure out if we could extract a tooth with an ice skate. If we can't, let's figure out how we could jury rig, take an ice skate and carve it up to actually use it to pull a tooth. And I still can't figure it out. So, and I'm a pretty smart guy, So, teeth can literally float in pus and fibrous inflammatory tissue. This is another x-ray over here. This is just a kind of a close-up, what we call a periapical film, which just shows a few teeth in the shot. This is the bone here. These are the teeth. You see this kind of, it looks almost like a veterinarian's cone of shame here. You can kind of see it right here. That's calcified plaque. That lady has never, well, maybe not never, but so rarely touches her tooth with a toothbrush that now she has calcified plaque that is actually built up around her tooth. It's gnarly, and it smells horrible, and it looks like barnacles when you look in their mouth. But the problem here is that she has dissolved all of the bone and the gum tissue that is around her teeth. So now the only thing that's holding her tooth in is fibrous tissue and pus. So when I touch these teeth, they move. They actually almost move when she speaks because they're so loose, and they smell awful, and they're just kind of swinging around in there. So we numbed her up, and then I just took them out with a piece of gauze. Like the whole thing was over in about 3 seconds. The point being, and the reason I showed you this slide, is because in a case like this, there is no other option other than to pull this lady's tooth out. You can't, you can't put she wanted to have crowns put on these teeth, like that was going to fix anything. People come up with all these crazy ideas from WebMD and stuff about what they need. People come in all the time and say, I need this and I need that. And they can tell me that they need whatever they want. Whether I'm going to do it or not is a whole different thing. Because, if somebody came, let's say that I'm a complete mercenary prick. And my big thing every day is to just make as much money as I possibly can. And with no regard for anybody's health, really. So this lady comes to me and she says, I want you to fix these teeth. And I say, oh, well, absolutely, ma'am. I'd be glad to fix them. We'll do a root canal on them, and then root canal therapy on them, and then we'll also put a crown on them. And we'll do it for $17.50 per tooth. So go ahead up front and cut a check to Sam, my receptionist, for $3,500, and we'll get cracking on these teeth. And then I could do root canal therapy on both of these teeth that are swinging around. I'm not sure how I would do that, but I could do it. And then put crowns on these teeth and send her out into the world. She'd be okay for probably another 6 months. And then they would abscess again, and she'd probably get quite sick. And then she would go to somebody like me in real life that knows what they're doing, and the guy would say, I'll gladly take these teeth out for you, and then please take these x-rays and go to the dental board for your state and file a formal complaint against whoever did this hack job work on you. Would I get rich as a byproduct? Sure. Would I have a guilty conscience? Absolutely. Would I be working in that person's best interest? No. So when I do my kind of stuff like this, the reason I showed you these is because she had actually gone to another doctor, and she said that she was not happy with the way these teeth looked, and she wanted to have crowns put on them, and the guy said that he would do exactly that for $3,500. I won't do that. I like to leave my office and forget about everything that happened at my office that day and go home and hang out with my kid and hang out with my girlfriend and watch TV and just be a regular dude and not have to think about this kind of stuff when I'm at home. If I did something like that, the $3,500 that it would cost me, or that I would gain out of it, all the guilt, all of the lawsuits, all of the $3 million aggregate that they're going to sue my ass for my liability insurance isn't worth it to me. So, what I'm saying is in a case like this, the best thing for this lady's health, aesthetics be damned, because sometimes we have to think about somebody's health instead of thinking about how that's actually going to look. It might look quite ugly for a while, but that's not our primary concern. Our primary concern is getting this person well. So, now comes the part where I say it's harder than it seems. Trust me. So, I pull teeth all day long. That's all I do some days. I don't do anything else. I walk into people's rooms and I say, hey, Miss Johnson, how are you today? Good. All right, well, your blood pressure's good, so we're going to go ahead and get you numb. We'll let it sink in for about 10 minutes, and then I'll come in here, take out all your teeth, trim the bone down, then I'm going to sew you up, and Samantha will give you some post-operative instructions, and then we'll see you back in 3 days. Okay? I do that every day. So, I pull teeth all day long, every day, is what I'm trying to tell you, and I've been doing it for years. At this point in my career, I think I probably pulled somewhere around 25,000 teeth, at least. Might even be more than that. It could be twice that. I'm not really sure. I know it's at least 25,000. I tried to keep track of them early on. Like I had this little journal that I bought at Barnes & Noble that had like some hemp leaves on the front so I wouldn't lose it. And then I put hash marks in every time I pull a tooth. And then it got to the point where there were so many hash marks it was hard to count them. It wasn't, counting by fives anymore wasn't expeditious at all. So I pull teeth every day. Some of the teeth that I pull every day are patients that other doctors have referred to me that they've tried to take the teeth out and they can't get them out. And the person ends up sitting in their chair for 4 hours with, somebody wrenching on their head when all they have to do is, maybe after, like Dirty Harry said, a man has to know his limitations, You have to know your limitations. I think about, things in the grand scheme. If it takes me longer than 15 minutes to take a tooth out, I start thinking like, what the hell is going on here? Like this thing's got to be bound in by some bone, or there's a tumor holding it in, or there's something that I'm not seeing, that I can't see on the plain x-rays that I have. I need to come up with a different plan. And I always do, and I always get the tooth out and everything's fine. But if I'm sitting there after an hour and I still can't get the damn thing to move, and then I'm sitting there after 2 hours and I still can't get it to move, 3 hours is getting to the point of hilarity and ridiculousness, and 4 hours, you should really think about maybe turning in your coat or going to be an orthodontist or something like that, because you are not cut out to be an exodontist. But this happens all the time. So it would be very hard or extremely difficult and challenging for me as an exodontist, as somebody that pulls teeth, to train people that are lay people in, say, like a 16-hour weekend course on how to pull teeth. It's just not happening. I teach CE classes to other doctors even on how I pull teeth. The Sherman House method for pulling teeth, there's not a textbook or anything, but it's just how I do it. It works for me. And they still have problems. So, I run into I call them humdinger cases. I have 2 humdinger cases a month where it takes me 15 minutes to take a tooth out. All the other ones, they just roll right out. And it has to do with technique. Yeah, I am a big guy, and I have big arms, not as big as Greg Ellifritz, but close. I have a lot of physical strength, but it is not a physical strength game at all. It's all finesse, and it's like old Jack Burton says, it's all in the reflexes. So, it's got nothing to do with physical strength, and it is a lot harder than it seems. So, I would say this: if you find yourself in a situation, if you're out there in the Virgin Islands and you are in a situation where you have to pull somebody's tooth, man, you got to be absolutely, stone rest assured that you can pull it off. If you have any doubt that you are not going to be able to do it, don't even risk it, because imagine if that tooth was in bone and you try and wrench on that thing and get it out because it's hurting and you can't get it out, and that's what it's going to turn into. You couldn't get it out before, you might not be able to get it out now. You know what I mean? So now
the compounding problems, if I try to get a tooth out and I can't,
Yep.
the further infection more problematic
Yep.
than just letting the thing there.
Mm-hmm. Yeah, it'll just get worse. If pain was the motivation for doing it in the first place, it's going to get worse. It's going to get more. So, this is a dental emergency kit. This is very basic. You can buy this one on eBay. Adventure Medical also makes one that's similar. Like I said, all this stuff is available on eBay. Also, the Tactical Medic, www.thetacticalmedic.com, has all this stuff on there. Sean Nealon, tell him Dr. House sent you. So the first thing you're going to want to have is gauze. The reason you have gauze is for a couple things. You can use it to control bleeding with direct pressure. You can use it, also, I use it to isolate teeth, so that there's not saliva and blood from the rest of the mouth that's getting on them. I also use it just to dry teeth off, because it's much easier to work on a clean, dry surface than it is to work on something that's all spitty and saliva and has blood on it. The next thing is cotton balls. Cotton balls are useful for a variety of things. Teeth are very small. It's microsurgery, basically. You're working in an area that is about the diameter of a McDonald's straw. So trying to fit a big pad of, this is a relatively small piece of gauze. This is a 2x2. Trying to put a 2x2 into something that's the size of a McDonald's straw, obviously it doesn't work. But these small cotton balls, they work a lot better. So you can apply direct pressure. You can apply medicaments of different kinds with that, and it just makes it easy. This is my favorite kind of filling material. I use this stuff every time. This jar right here lasts me about 2 weeks. It's called Cavit, C-A-V-I-T. It's made by 3M. You can also find that on eBay or from medical supply stores. That stuff is really easy to work with if you're not skilled. It's semi-sticky, but not so sticky as it makes it, it doesn't compound the situation. The best way to do it is you kind of just scoop out a little ball of it, roll it up in your fingers, you have gloves on, of course, roll it up in your fingers, put it into the tooth, and then take one of those cotton swabs, wet it, and then kind of roll it over the top and sort of tamp it down with that. And then don't let anything touch it. Like put a piece of gauze over it, and don't let anything touch it for about 5 minutes. The stuff hardens up to almost like a cement type consistency, and then you got a temporary filling in place. Now, people will say, other dentists will say this to me when I tell them that I teach this kind of stuff to lay people or to non-dental healthcare providers. How can you be teaching people to put temporary fillings in the teeth? It makes it so dangerous. Well, here's the thing. You're not going to put a temporary filling into an abscess tooth. I think everybody here is quite clear that if you have a tooth that is exuding pus, you're not going to do anything to it other than get that person evacuated or get them to a healthcare provider that can pull the tooth, right? Okay. So the things that we use temporary filling material for is if the filling falls out. And we need to put a temporary filling back in its place. Or if a tooth breaks, and we need to put a filling back into its place. If it improves that person's quality of life and allows them to eat and hydrate, now that person can still walk out. If they're hurt so bad that they can't drink water and they can't eat food, now we're going to have to carry them. And you don't want to do that. I don't want to do that. I don't want to carry anybody. Half the time it's hard to carry my own fat ass around. So I don't want to do that. So temporary filling material is not going to make anything worse. If somebody has a filling that falls out and they go get it fixed and you need to get a root canal therapy performed on it, you probably needed root canal therapy performed on it before you put the temporary filling in it. So no love lost there, folks. It's just what it is. If it gets you enough comfort to be able to get you back to civilization, then it performed its role, okay? And it's a temporary filling material. Temporary means temporary. So it's not going to stay in there for months and months and months. You're going to keep it in there for as little time as possible, maybe 10 days at the most. As quick as you can get somebody to a provider to be able to fix it would be best. So everything else here is pretty self-explanatory. The mouth mirror, cotton pliers. These are locking cotton pliers, which are useful. See, they have a little lock right here. when you pick up a piece of cotton and you hook it together, it actually stays in there, so you can dab with it. That's why those are useful as opposed to a regular pair of tweezers, but a regular pair of tweezers works fine too. I carry like a small LED flashlight with me everywhere I go. I carry, instead of like a big huge Surefire or something, because I can hold this in my mouth and it doesn't wear a hole in my pants, and I can wear it with a suit if I have to, and still, not look like Tactical Ted. But also more importantly, I can hold it in my mouth when I work if I have to, and it's not so heavy that it makes me drool, and or it hurts my teeth, from having to bite on it. I don't want to do that. That would be counterproductive to my mission. And then pharmaceuticals. This is an important part right here, is a bottle of eugenol or clove oil. And clove oil and eugenol are basically the same thing. Everybody knows what cloves are. They smell nice, and you probably made an air freshener out of it when you were in the 2nd grade for your grandma. Or at least I did. But anyway, clove oil is a very useful medicament for sore teeth. And if you take a cotton pellet and you soak it in some eugenol and then kind of dab it off so you get the excess, and you put it down in the tooth, it actually kind of sinks down in the tooth, and it has a calming effect on the tooth. You could rub Ambisol on the gums next to it, and it's not going to do a damn thing. But if you apply that pellet with the clove oil or the eugenol on it, it actually calms it down. And they used to do that routinely back in the day, when endodontics wasn't as readily available as it is now. And by endodontics, I mean root canal therapy. Root canal therapy used to be planned. Now, if somebody says, if you come in and I say, you need a root canal therapy performed today, literally it takes me 5 minutes to get my people to set that thing up. So back in the old days, it wasn't like that. So they would do these sedative fillings, is what they called it. And it still works for emergency kind of stuff, and it still works for austere environments. So that's what I like to use for that. Lastly, it is useful to have a tube of Ambisol, or 20% benzocaine. The brand name that I like to use of that stuff is called Hurricane, and it's 20% benzocaine. And it's useful for a variety of things. It's useful as kind of as like a part of your snivel kit, if you have a bump. Like, I remember one time I went to a shotgun class, and they said, hey, you got to try out this new Hogue short stock on this shotgun. And I said, okay, I'm 6'4". I don't really need a short length of pull stock on a gun, but I shot it anyway with a slug, and my thumb hit me in the right canine like so hard that it knocked my tooth loose. And I was like, son of a bitch, that was stupid. Why did I even think about that? And so I had that in my kit. I rubbed some of my gums for a couple days. The tooth tightened back up, and everything's fine. But, it wouldn't have been fun to, endure through the rest of 600 rounds of double-aught buckshot and Uncle Paul yelling at me to get, with a sore tooth. So, there's that. Okay, so medications, over-the-counter pain medication. You look at this picture here. This is a 43-year-old woman with a mustache. No, I'm just kidding. 43-year-old man, African American, has all of his teeth, 32 teeth. Came to us because he started to have wisdom tooth pain. We took an X-ray and showed in the X-ray that the wisdom tooth was actually coming in sideways, and it was coming in at a trajectory that was pushing on the second molar in front of it. And that was causing him pain. So we took the X-ray and looked at the X-ray and realized that there's something going on with the tooth here that's out of the norm. And what he had was a benign tumor called a dentigerous cyst. That's the only time you get a tumor, a cyst like that, is if it's associated with an unerupted tooth. So this is one of the hazards of not getting your wisdom tooth out before you're 25 years old. He didn't. But, he was busy. He had undertaken a life of crime at this point and was in the correctional facility. He was actually a federal prisoner. And he got busted for one of these operations where you take a bunch of people that are professional junkies, put them on a bus, take them down to Florida, take them down to Pensacola, send them to every urgent care center in the area, and have them get prescriptions for pain medication. Then you go to pharmacies and fill them. Everybody gets back on the bus. Then they drive back to Tennessee and sell them all over town. He was driving the bus. So, this is where I saw this guy. So now you're thinking, well, what does that have to do with over-the-counter pain medication? Well, people that are wards of the state or inmates of any kind do not have access to narcotics while they are in general population. This is considered outpatient surgery, meaning this guy comes to my office in handcuffs and leg irons. They undo the handcuffs, he sits down in the chair, 2 corrections officers stand at his feet, and I do the work while they sit there. Then they re-chain him, then take him downstairs, put him in a van, and take him back to the prison. So, I'm not going to give this guy any narcotics. He's already had enough fun with narcotics in his life. He doesn't need any more. So this wound here is big. If you actually looked at the post-operative x-ray, the x-ray that we took after we took the tooth out, you'd see that there was only about a 1/4 inch thickness of bone that's left in his jaw between the jaw joint and, down here at the angle of the mandible. So very, very thin. If he bit into like a Subway sandwich, it would have fractured his jaw. So he was on a soft diet. He's probably eating mashed potatoes and cream corn and all the rest of the Cracker Barrel senior citizen diet, for probably 8 to 10 weeks until this was completely healed up. And then he would, go back to his normal life. And he healed up fine. My point being is I managed this guy's post-operative pain solely with ibuprofen. Ranger candy, you can do a lot with 800 milligrams of ibuprofen. Anybody that tells you otherwise is a liar. The big thing is people always tell me, ibuprofen doesn't work for me. And I say, how do you take it? And they go, well, I get a headache, I take about 15 over-the-counter tablets, and it doesn't go away. And I go, well, first of all, you're probably in kidney failure now. Second of all, you have to take it dosed accordingly. And what I mean by dosed accordingly is it's a dose-dependent medication. You don't get a clinical effect off of it from just one dose. You actually have to take it and then take it again. The reason being is kind of twofold. It's concentration dependent. It takes enough, you have to have enough of it to be able to get it in your bloodstream to work. If I take an 800 milligram tablet, I weigh 250 pounds, I'm a healthy guy, I drink occasionally, my liver works swimmingly, it's, even though I'm taking 800 milligrams of it, only about 350 milligrams is actually going to reach my bloodstream. The rest is going to be destroyed by my liver. So, I take that. Now, 8 hours later, when I tell you to take another pill, you still have some ibuprofen in your system. Now you take another pill. Now we add another 350 milligrams or so to it. So now you have about 500 milligrams in your system. And you're going to have that for about the next 6 hours. But you're going to take another pill in 8 hours. You see where I'm going with this? So you got to look at the half-life of the drug versus the timing when I'm telling you to take it versus how much you have in your blood concentration after your hepatic first-pass metabolism. So there's math involved in all this. However, for the regular person, it's all condensed onto the side of that bottle that you get that says, Dr. House says, take 1 tablet every 8 hours as needed for pain. So that's 4 times a day. So you're not going to take more than 3,200 milligrams of ibuprofen in a day. That's 4 times a day. 8 times 4, 3,200. So 800 milligrams we're talking about. If you only have over-the-counter tablets, over-the-counter tablets are 200 milligrams. So you would take the corresponding number, which is 16 in a day, is the maximum amount. For adults, kids are different. So this is different for kids. A kid dental lecture would be a whole different lecture.
Doc, what I've done in the past, I actually took this stuff with jaw surgery. I got my jaw cut apart. Ibuprofen or Motrin, and then 4 hours later, acetaminophen. And then 4 hours later, ibuprofen or Motrin. That's what my doctor told me to do. I just wondered your thoughts
You can do it. That's primarily the best thing to do for fever control. You know, like
Right,
in
because
kids.
I have an infection as well.
Yeah, but you know, I would say the only time I really have people alternate drugs is if it's alternating a narcotic, you know, with a non-steroidal anti-inflammatory. So Lortab 5, you know, you take that. 4 or 6 hours later, you're going to take a Motrin, and then you're going to take another Lortab 4 to 6 hours later.
So if you're not taking narcotics, there's no real advantage.
I don't think there is. There is for fever control,
Okay.
but mostly that's something that you would do in a child.
Got it.
Yeah, kids' fevers are harder to control than adults. The adults are pretty easy to control.
So if you're dealing with a child with something with pain, it may not be bad to give them a low dose of acetaminophen with
For fever control.
for the but only if they have fever.
Yeah, if it was a kid and they were having pain, I would just use the Motrin.
Got it.
Motrin's like a surefire spear to the heart, man, every time. If you dose it appropriately. So don't, you know, if you are, you know, if you're the medic and people are saying like, I can't take ibuprofen, it doesn't do shit for me, you know, like, say, look, suck it up, Buttercup, this is how you do it. Take 800 milligrams 4 times a day, every 8 hours,
Just tell them you're giving them all
or every 6 hours rather, and you'll be fine. Yeah, and it works. It absolutely positively works. So all of the oral surgery that I've ever done in a correctional facility, I have managed with Motrin. And people aren't allergic to it. They only tell you that they're allergic to it because they want you to give them a narcotic. Nobody's, I mean, have you ever seen anybody that's legitimately allergic to ibuprofen?
No.
I never have. Or they'll say, I'm allergic to it. Well, what happens when you take it?
After
Oh,
my-
I get a tummy ache. Like, not allergic reaction.
I'm allergic to lower tack, codeine, everything, and so after my cancer surgery, if I was in pain, I took Motrin,
Yeah.
and it's fine.
Oh.
So,
Yeah, it's, you know, being allergic to narcotics is more understandable because, you know, it's interacting in a different way than this is. And, you know, most people that are allergic to codeine are also allergic to, yeah, I'd say they're more sensitive to like Lortab, to hydrocodone, and maybe occasionally to oxycodone, but not necessarily.
The only reaction I've ever had giving an NSAID was a soldier who we'd been road marching all day and he had colitis, and it was with his Remicade. And he
Sure.
I didn't know about the Remicade. I knew about the colitis.
Yeah.
I didn't know about the Remicade. And he comes to me. He's like, "Doc, I got a headache. Can you give me something?" I was like, "Yep. Ranger candy. Here you go. See you later. Go take a nap." He comes back. He's pale, diaphoretic. He comes back and tells me he's been puking and shitting his guts out. And I was
Yeah.
like,
Yeah.
"Roger, what'd you take?"
Yeah.
He told me that I need to take him to the hospital because he's not supposed to take Motrin. Well, you should have told me that 2 hours ago, pal. You know, like,
Yeah.
that's the only contraindication I've ever seen.
Yeah, I mean, you know, like, if somebody has a history of GI bleeds, you know, you're not going to want to give them an NSAID. If somebody has, sometimes people have cross-reactivity to NSAIDs also with asthma. And then, of course, with
With what? Asthma?
asthma, right. And then, of course, with expectant mothers, you're not going to want to give an NSAID because it increases the chances of them
Raise.
having, you know, septal defects and arteriovenous fistulas and all this kind of stuff. So,
What about her?
it'll make it worse. Yeah, but you know, like
better
like
than
what's, yeah, we gotta kind of analyze the risk and benefits of it, you know? Okay. Whoops. All right, so this is for narcotics, now, like you're gonna say, okay, this is the narcotics that you use, how do I get them? Well, you'd be amazed at the number of people that come to me, and probably, you know, to some of you too, and they already have their narcotics. They you know, my mom had hip surgery, and so I have these narcotics from her. Or I had, you know, a shoulder replacement done 6 years ago, and I still had a bunch of Percocet. So, you know, it's out there. If you, depending on the environment that you're in, you know, it can be had. And believe me, it can be purchased in nearly any urban area. What's that?
or eating.
Yeah, yeah, on eBay. So I use Norco 5 milligrams a lot. That's probably like my #1 prescription that I write for narcotic analgesic. I use this other stuff occasionally, situationally dependent. You know, if you want to look it up, each of them, they basically just vary in the concentration of the medication that's in it, whether it's hydrocodone oxycodone, or tramadol. So they're just, all those are compounds, so they're more than one medication. I don't often use these ones down here. The higher dose, oxycodone, like 10 650s and stuff like that, I don't hardly ever use. Just because my big thing is, and I found that the shorter the amount of time that I leave someone's bone exposed to the air, the better they do. So if I have a really, really prolonged extraction, case, and by prolonged for me, I mean 20 minutes, then I'll give somebody something that's a little bit heavier. But these ones where I'm like in and out of there in 3 minutes or less, I just don't think that it doesn't do me any good to stone that person and make them obtunded, for a couple days just out of convenience. So, I'll still give them, probably just the ibuprofens, and they'll be fine with it. So can you manage other types, can you manage dental pain and post-operative pain with other opiates? Like grandma's got some fentanyl patches laying around. Can you use those? Absolutely. It's going to be a humdinger, but it'll do it. When I work in the emergency room and stuff, a lot of times they have, they don't have this. They might have this stuff in the Pyxis system, but more commonly, they have Dilaudid, or they have fentanyl, or they'll have morphine sometimes too. And you can give small doses of that and titrate it for effect, just like you would for any other thing. So the take home that I want you to have from that, though, is that about 95% of all of this pain that comes from these dental issues, whether it's post-operative, or actually experienced pain from the tooth itself, can be managed by NSAIDs, by Motrin, or lead, or something else that's in it. So antibiotics. This guy right here, I took this picture. The bottom looks just the same. This is a 26-year-old man, methamphetamine addict. Doesn't work. Stays on his mom's couch all day long. Occasionally goes to Walmart to buy Mountain Dew and Fritos. And I always take these pictures to document for insurance purposes, even though they don't always have insurance, to show why I'm taking out every tooth in their head. I think that any reasonable person would look at this and go, I could see the clinical need for that there and why we shouldn't deny this claim. It's stupid that I have to do that, but I do it just because I like to get, it's like the Joker said, if you're good at something, never do it for free. So I'm not going to take out all this guy's teeth and then trim down all the bone and then stitch it all together nice like a football and not get paid my piece of that for my 45 minutes worth of work. So in this guy's case, this is another one where if we looked at the panoramic x-ray, we'd see that he has 32 teeth, and probably 20 or more of the teeth have abscesses that are about the volume of a sugar cube. So I take out all of those abscesses and I take out all of the granulation tissue, these balls of pus that are inside each one of these sockets when I do the surgery. But I also will give him an antibiotic just because I know that it's impossible for me to mechanically scavenge all of that crap that is left in there. So in a case like this, I'll give an antibiotic. But routinely, for most extractions, and dental injury, I don't give antibiotics. Unless the patient has a comorbidity that would lead me to believe that they have impaired wound healing for whatever reason. Some examples of that would be if somebody has like COPD. They're not breathing well. If they're diabetic, they're going to have an impaired immune system anyway. If they have anything autoimmune going on, I'm going to give them antibiotics. If they are a multi-pack smoker, I'm going to give them antibiotics. So most of those people, they get antibiotics. And the most common thing that I'll give people is one of 3 derivatives of penicillin. I either give penicillin with potassium, which like if you go to a Publix is free. So that's helpful for people. I give them oxacillin. These are all in 500 milligram strength. Or I give augmentin. I give augmentin specifically only for molar teeth that I do on the upper, where I end up having communication with the sinus floor, and I have to close it just because it works better on all the bugs that live up in the boogers and in the nose. And so we don't want that stuff to commingle with the mouth And so, I do a surgical closure in their mouth, and then I put them on that just to make sure that everything gets scavenged appropriately. Now, if people are allergic to penicillin, the first drug that I go to is clindamycin. And clindamycin is a great drug to use. It's very effective for all of the bugs that live in the mouth. The problem with it is that if you take it wrong, or I say take it for 4 times a day for 10 days, and you don't listen to me, and you take it 3 times a day for 15 days, or thereabouts, you really increase your chance of getting like what we call, antibiotic-induced colitis, or, antibiotic-induced pseudomembranous colitis, which means that you will get the irretractable shits so severely that you can become dehydrated, sick, ill, and die from that. So it's kind of a slippery slope. I try not to give it, and luckily people aren't often, allergic to penicillin that I need to give that stuff to. But when I do, I'm always very cautious, and I tell people, absolutely make sure that you take this 4 times a day. If you have to set an alarm on your phone to do it, and only take it for 10 days. So, and I wrote clindamycin 500 milligrams. It should say 300 milligrams. Doxycycline is also a good drug. I'll use that. I use this also for people that just have gum disease in general. And it actually has a good clinical effect for gum disease because it works on the bacteria that cause periodontal disease. So it works good for that. It's also a good antibiotic to have for preparation in general, just because it works on other things. It works on genitourinary problems. It works okay on some skin problems. And then same kind of thing with Keflex. Keflex is another kind of multi-purpose one. The only thing is you don't want to give Keflex to somebody that has a penicillin allergy, because it has the cross-reactivity to that as well. So, okay. So, this is kind of a crowd participation moment.
I remember this one.
This is a patient that showed up in my office. Now, what do you think is causing their pain? Well, you remember when we talked earlier, and I talked about the density, the densities, and when I look at an X-ray, I'm looking for changes in density. So when I looked at this X-ray and got this, well, I knew what the guy's story was because he told me as soon as he came through the door, because he kind of came through the door in a bit of a huff. And the reason that he came through the door in a bit of a huff was because this is in my South Nashville clinic, which is all Spanish speaking. It's in the middle of an MS-13 and Kurdish Pride war zone where they shoot it out and try and kill each other on a regular basis. However, this guy wasn't actually shot in the face in Nashville. He was shot in the face in Mexico City. He left Mexico City quickly, went to the border, went to some first aid station there. They gave him a gram of penicillin G and some Lortab and said, bienvenidos de los Estados Unidos, amigo, and sent him across the border. So he got on a bus and hauled his ass up to Nashville. 3 days later, he comes to me with this just big periorbital swelling, a small dimpled entrance wound here, which you can see right here. That's where the bullet went in. It went through, just straight down through his sinus. And then his first and second molars used to be right here, along with the tuberosity, his maxillary tuberosity, which is, if you put your finger all the way back in the back of your mouth, that little saddle hump of bone that sticks down. It blew that out into the floor of his mouth. It also blew the sac that's in his sinus out into his mouth. And then the bullet exploded or fragmented, and you can see where it starts to leave spall here, 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 here. Now, imagine this. Now, this is, you got to think here. You kind of have to close your eyes and think about this. You're looking at a curved bone that's been flattened for the sake of illustration here, okay? So the bullet comes down and it hits here over in front of this parotid gland, which is this kind of meaty thing at the angle of your mandible. And half of the bullet stays there. That's this. This is the jacket of the bullet. This is a 45 caliber, 230 grain Hydra shot. So it broke. The bullet broke here. Now the core inside the bullet did this bizarre JFK-esque grassy knoll loop-de-de-loop and came all the way over here, and the bullet rested in front, almost just below his, just right level with his earlobe, right here. And because of where it actually came to a final resting place, it mechanically prevented his jaw from opening. So the reason he came to see me was because he couldn't, abro la boca. No se habla la boca. I'm like, you can't open your fucking mouth? Like, what? And then I find out that he's been shot, and then I look at this, and I go, why did you come to me? And he's like, I won't, be insulting and do his accent, but he said, I knew that you were a doctor, and there was a subway over there, and you're over here. So I came here. And I said, okay, well, I mean, they really wouldn't do anything for you at Subway. Luckily, you came to somebody that could help. So I called up one of my buddies, that's an oral surgeon, and I said, hey, how would you feel about retrieving a bullet for free in your office? And he said, are you going to come over and help? And I said, shit, hell yeah, I'll be right over. And so we got this guy in my car, and drove over. Now, I took a picture of this x-ray, and I also took clinical photos, which I won't show you because they're really not interesting, because they're very not dramatic for being shot in the face with a .45 caliber bullet. But I took this picture, I sent it to one of my friends, James Yeager, I sent it to Greg Ellifritz, I sent it to a couple of my other friends that are in the law enforcement, military, and tactical training industries. And I sent a little, description of the case, like how it happened and the date and whatnot. And it went like viral. And before I knew it, people that I didn't even know were putting it on their tactical websites and all this kind of stuff. So fast forward back to January, I was at another conference that was just primarily tactical stuff. And these dudes were talking about it. And they said, oh man, there's this dude who got shot in the face by a hard shock, and I don't carry a .45 anymore because of that, because obviously the stopping power of that thing is nil. If this guy got shot in the face with a .45, and then he fell to the ground, was only unconscious for 3 minutes, and then he got up, and his gums were hurting so bad that he went to a dentist. Like, if he was well enough to go to a dentist, then obviously the .45 caliber round has no stopping power. And I said,
That was not the point.
that's not how it happened. And he said, yeah, I did. And I said, no, that's not how it happened at all. And he goes, how do you know? And I said, because I took the picture. It was my patient. I was the doctor. Oh, I'm Dr. House, by the way. And he went, oh. And I said, yeah, it didn't happen like that at all. And I told him the whole story, and then everybody was like, oh, okay. But yeah, it was kind of a weird thing. I woke up one morning and somebody said, hey, you're famous. And they said, go to Clint Smith's Facebook page. And I go there, and Clint Smith from Thunder Ranch is talking about my case. And I thought, well, that's weird. I've been reading this guy's stuff since I was a teenager, and now he's reading my stuff. So you never know what's going to be causing somebody's dental pain. It could be a bullet. So, we're getting near the end here, but I just want to say these are my 3 favorite dentists in popular culture. This is, Dr. King Schultz from the movie Django Unchained. This is Dr. Jesse Haywood, played by Don Knotts in the 1968 film The Shakiest Gun in the West, which, if you've ever seen that movie, I like it because it starts out, he's at the University of Pittsburgh dental school. And it actually shows him when he's in dental school and he's having to work on all of these crazy people. And that's exactly how it is when you're in dental school, because you never have normal patients to train on. You always have to work on people that are, they're not, it shouldn't be in society otherwise. That's what they do. They get up every day and they go to teaching medical facilities, and that's their career. That's what they do every day. They go there to get their teeth fixed. They go there to get their pelvics. They go there to get everything done, and we all end up working on them. And a lot of times you can work out deals with your friends like, hey, I'll trade you a lady that needs root canal therapy if you send me somebody, that needs a pelvic, da-da-da-da-da. So there's this good cross-pollination that goes on. But anyway, and then of course everybody knows Val Kilmer there in Tombstone as Doc Holliday. Also a dentist. All right, so just the review of the learning objectives. I explained how dental injury or infection can result in debilitating pain, disability, or even death. You now understand preventive measures which can keep dental issues of all kinds at bay, and then you can assemble and use an intuitive dental emergency kit, and you can understand which over-the-counter prescription medications are useful for the management of dental emergencies. So I thank you for your attention, and if anybody has any questions, I'll be glad to answer. Yes, sir.
Good question about flossing.
Uh-huh.
Is there like regular floss, like I use a lot of the floss picks,
Mhm.
the reach.
If you're using any of those, I say kudos to you, man. Any of them will do. Anything is better than nothing. Like I use the Dyneema ones, they're actually made out of that failed ballistic fiber that they found out for contact shots basically turns to a pillowcase when you shoot into it. It works really good for dental floss. It's exceptional dental floss. And if you have really tight contacts in your teeth, like I have really tight contacts, like I can cut any piece of floss with my teeth. With that stuff, it just passes right through. So and they're green and they smell minty. And I use about 200 of them a month.
What's that called again?
Dyneema. They're called Plackers is the brand name.
Okay.
Yeah. And you can get them at Walgreens or Walmart, wherever. They're in a green bag.
Yes, I have trouble with flossing.
Yeah.
Always cutting the floss.
Yeah. That's the best thing. I mean, you can't break those things. I use them at work sometimes to like get stuff out of people's teeth that they've stuck in there. They're really durable.
So I get prescribed hydrocodone sometimes for dental pain. I started declining it because it makes me so nauseous. I'd just rather have the pain. So then instead he prescribes Meprogan with Phenagrin.
Yeah. This is your dentist does this?
Yeah.
Really?
Yeah.
Huh. What does he fix your teeth when he does this?
Yeah, sure.
And then he gives you Meprogan?
Sometimes.
Wow.
It's rare. I mean, it's 2 or 3 times in 20 years.
Wow. Huh. Okay.
So why wouldn't you just prescribe an anti-nausea like Phenagrin with hydrocodone?
Because when you give, like Phenergan, like you said, like an antiemetic with a narcotic analgesic, it kind of has a synergistic effect that works out beneficially for you, but doesn't necessarily work out beneficially for us because we might give it to you and then you go, yeah, I'm cool, and then you go get in a car and crash your car because now instead of just being high, now you're high and stoned and half asleep. So you'll notice if you take a narcotic, it'll make you feel kind of fuzzy. Things get hyper acute, sound weird and stuff. But if you take it along with the antiemetic, like Phenergan, Compazine,
It's just about getting narcoleptic.
yes, it's very hard to stay awake. Like it is, like sometimes you can actually do conscious sedations almost with it. So, yeah.
What about Zofran as an
Zofran,
alternative?
same thing. I mean, not as bad.
There shouldn't
but-
be as much compromise, at least. for
Correct.
us.
Yeah, I would say that would not, you would get everything you wanted, but not necessarily as bad as
Right.
you wouldn't get any of the adverse effects. Yeah.
Yeah.
So, anybody else have anything they want to add?
What do you use to pull the teeth? Where do you get the teeth pulling pliers?
You can buy everything that I use to pull teeth on eBay. I won't tell you how though. That would be disingenuous of me to do that. Like I said, that I undo other dentists' problems all the time. And if somebody that graduated dental school before I was born can't figure it out, it would be really hard for me to explain to you how to use this stuff.
So based on his question earlier, if it was a survival situation and you've already
The best thing to do is, and like, here's the funny thing. I've asked almost every one of these lectures that I've done. This is the 3rd one. How many people in this room are actually friends with their dentist? Really? You guys are the first ones.
Really?
Really?
Like your friends, like you've been to their house?
Yeah.
Yeah.
Are you serious?
Serious.
Shooting. Yeah.
Nobody's ever been to my house. Nobody ever comes over to
Do
my
you
house.
invite
No.
Well, there you go. I wouldn't invite your patients either.
The best,
to your house.
yeah, most of my patients, they
Actually,
might show up at your house, but it's not
You
because
don't
you
want
invited
to.
them. So, they're gonna come over and drink all my good booze. The best thing that you can do for preparedness, honestly, is befriend a dentist. And that's kind of a tall order in and of itself, unless you golf and wear a lot of polo shirts or whatever the case may be. But that's the best thing, because if I have just a rudimentary amount of supplies, I can do anything I can do in my office. It's just not going to be as quick, but I can do it all. I've done all of this stuff that I've shown you guys here. I didn't talk about, I just talked about the patients. I didn't talk about where I did it, but a bunch of those have been intense. A bunch of them have been, in military outdoor operatory theaters. in schools, yeah, I mean, I've done them everywhere. I've done one in somebody's basement one time just because that's where we were. You know, I didn't really have much of a choice in the matter. We got a desk lamp and
Did you have a gun to
and a
your
chair. Huh?
Did you have a gun to your head?
No.
Our hygienist and assistants trained, rudimentary trained to help or at least do extractions.
No. They know how to help. And most of them have watched enough that they could probably muddle their way through it.
Just
Not most of
basic
them, but
extraction,
probably
maybe.
1 out of 20 dental assistants is good enough that they could do it. And occasionally, if the patient is like really cool, you know, or they have their eyes closed really tight, and the tooth is very mobile, I'll get a good clamp on it, and then I put the dental assistant's hand on it just so they can feel how it feels, and then I'll move their hand and show them the extraction force that you need to pull the tooth, and then they go, hey, that's cool, and I'm like, yeah, you'll never do that again. So anyway, yeah, so yeah, they're also a good resource to have, but yeah, you know, I wouldn't say that they could do it, you know.
Oh, right. I mean,
Yeah.
just we use text
Yeah,
for the
same thing.
majority of our
Yep.
stuff, but dentists, of course, do
Their own thing, yeah.
the thing. But you know,
Yeah.
in a pinch,
Because the government
come
can't
here,
sue
you.
the
Can
government.
you pull this tooth?
Yeah, exactly. Yeah, yeah, and that's the, you know, that's the crazy thing is, you know, like the reason that you couldn't, you know, sue the guy that took 4 hours to get your wisdom teeth out is because,
Well, because they're freaking.
sorry, you're government property. So yeah,
I
yeah.
volunteer to be government property then.
If I did something like that, if it took me 4 hours to get 1 wisdom tooth out, like I said, I would be thinking, boy, maybe I should be an orthodontist or something else, you know, oral medicine professor, because probably, you know, the field of hands-on getting bloody kind of stuff is probably not for me. So, yes, sir.
You know a good dentist in the Knoxville area?
Knoxville?
I don't know, drive you 3 hours to see you twice a year.
Yeah. I not off the top of my head. I'm sure I know somebody there that I went to school with, but not off the top of my head. But if you take one of my cards, you can. I have cards here if anybody wants one. If you want to, my email's on there too. And if you need anything, you know, you can
Sherman,
hit me up.
for
Should I come over, drink the booze?
a guy who's trying to get some extended training stuff, like this guy is a Keith Brown still
Yes,
doing his teeth course?
he
still
is.
doing
I
that?
think.
That would be something probably good for somebody like
Yeah,
that.
yeah. There's a guy named Keith Brown. He's called Rescue Doc, and he does, you know, kind of like austere medicine stuff.
It's
He has
Outworld Medical Services.
What is it called now?
Outworld, I think it is.
Oh, so it's not Gore
it's
Group
not.
anymore.
No, I believe it's Outworld
Works
now.
out.
Yeah. He's a good guy. Keith's a good friend of mine. We've done a few different live tissue lab and classes together, and he's a good resource too.
He
for that
was-
kind of thing.
Had a 5-day just teeth.
Yeah.
Have to go to a foreign.
If you're worried about
exact with people's
austere and
teeth.
disaster
Yeah,
medicine,
he knows it.
He's-
Yeah, Keith and I
Yeah.
also have the unique common shared experience that we both got viral endocarditis from working on foreign patients, and it damn near killed us. So yeah, it's